Hello, everyone, and welcome back to Physio Minds. I'm your host, Alex, and this is our co-host.
Theo, what's up, guys?
Nice to see you guys again. And today we're going to be talking about post-graduation next steps. So let's say you've been in the workforce for maybe a few months now, starting to get into the swing of things, full caseload, and you're going through your routine, treating your patients, and you come to a mental block. You're like, I don't know what else I can do treatment wise for a patient. Or maybe you start thinking of different ways that you can do interventions in order to get better. So today what we're going to talk about is, you know, what do you do next? And what are your thoughts on what do you want to do afterwards? Theo and I have talked extensively of what we want to do next, and we're just going to share a little bit of information about both of us and what we're thinking and what we want to do in the future. Theo, why don't you go ahead and tell us what you've been doing in your next plans?
Right. So, as I mentioned, I work in outpatient general facility, so I see a little bit of everything, which I love. And I love my neuro patients, I love my ortho patients, all that. But for me, my real passion is orthopedics. I've known that for a long time. And even during PT school, I remember, getting taught by some people that were like fantastic therapists, and they had a fellowship in orthopedic manual physical therapy. So for me, that's always been like, okay, like I want to be like them, like I want to treat at that high level. Um, so that's always been my goal, and so I've been always working towards that. Now that I've graduated past my boards, I've been working. I've started to work on the first step of my plan, which is my manual therapy certification, which I'm almost done with. I have one more course to take, and then I sit for the exam, which is pretty extensive: six oral practicals, six oral, and then skills practicals, and then a written exam. So again, pretty comprehensive. It's like a 3 weekend, three day thing on a weekend. And then after that, I plan on, starting my fellowship in orthopedic manual physical therapy, because I think it's important, to one, use the stuff that you learned during the classes, that you learned in school, to those interventions. But those are very entry level interventions, like we talked about last time. There's some interventions are better than others, and not even that, just knowing different ways to do the same thing, right, in different positions. Like maybe you learn something for a patient that's in, that you learn that skill in on the patient's lying down on their stomach, but they can't tolerate that position. So how are you going to do that now? So being able to do the same intervention, get the same result in sitting, for example. And I think it's important, to be like flexible in your treatment approaches. So continuing to strive, for that and constant improvement. So for me, that's the route I'm choosing to take, at the moment. And then after I finish my fellowship, who knows, maybe open up my own practice.
Yeah, absolutely. Yeah, I mean, the good thing is you know what you want, you're going for it, you're taking your time looking into what you think is the best steps for you and how you can get there. The biggest thing I can say is like have a mentor. And I think both of us talk to a similar mentor to, guide us of what we think, what we want in the future. And they're going to give us that information and they're going to be true to us about it, which is really good. I know for me and the company that I'm working for that they have like these balance levels is what they call it. So balance one, two, and three. So like different types of balance exercises, very vertigo and vestibular heavy. I know I've completed balance one course. I've completed a couple orthopedic courses from when I was at this company during my clinical, and I've completed like a multi-regional core course, and then I've completed like a lumbo-pelvic stability course, a cervical thoracic course. So kind of just different things, and in terms of like orthopedic wise. And some things I'm looking forward to in the next 1 to 5 years is dry needling, manual therapy course, and possibly a fellowship. It just depends on where I am and how I think I'm get treating my patients, and if it's, if it's working if it's working for them, I'll keep it. But I've noticed that in the past 3, almost 4 months now that I've almost hit like this, like a mental block where it's like, dang, I really wish I knew more about what's going on. And that's when I start to research through like article journals, through since I don't have access to USA, our old school where we had our article EBSCO and all that stuff. I go through the APTA now. I'm a member through there, and I'm able to look up different orthopedic articles, neurological articles that actually assist me through, getting my patient better. Because if I'm stuck and I'm like, all right, let me look up interventions, or let me look up more about this pathology and how rehab can be affected, I either call Theo or I text like other physical therapists or talk to people around you, of course. But if you want to do more research yourself, it's a good way to look at it.
Right.
Um, yeah, I don't know, Theo, if what you do, if you get stuck
And
afterwards.
again, like I said prior, like for me, I'm lucky to have like great mentors. And where I work, especially, I feel very comfortable like speaking to my supervisor, especially when it comes to like in my neurologic caseload. He's actually one of the professors that teach those neuro classes. So, there's like he has a lot of knowledge to share and a lot of experience in terms of prognosis. Like, is something going to actually get better, or is it not? Because with those neuro caseloads, sometimes it's not about returning the patient part of a function. It's about maximum functional potential.
Right.
So I've been blessed to have mentors like him, and like you mentioned, like we've shared some common mentors, and I think it's been really helpful speaking with them right after school and just kind of like, okay, like knowing where you want to go. Like, I want to take this route. For me, it was fellowship, and it's my question to my mentor was, okay, like what what job should I take? What am I looking for in a first job in order to reach my goal? Um, and the guidance that he gave was invaluable, um, and and again, like the mentorship is very important everywhere you go. I think furthermore, with when it comes to continuing education, we were trained, and like Alex and I were both trained in a certain way, a certain approach to treating, which has worked great for me. It's my patients seem to like it, they're getting better, right? But I think it's also important to branch out a little bit and not just stick to the same thing that and just continue with that. Seeing different ways of thinking, and that way you can combine everything into your treatment and make it your own, right? Make it unique, make it because if something doesn't work that you've learned, all right, like what about this? All right, let's try that. Okay, that works. All right, so is that better than my treatment, or or worse, right? Like what is it? So it's important to be able to bring in everything, and and different approaches, because to me at the end of the day it doesn't matter. It's not as important what I do as long as the patient gets better and the results speak for themselves. So
Yeah. Yeah, that's a big thing. I feel like I've seen in a lot of students, and I've talked to a couple students prior, and what I've said in the past is like, keep your mind open. Like, I know our school is very Stanley Paris heavy, so it's very specific. And then you can get into, McKenzie method, and then you have Ola Grimsby, and you have all these other methods that Kaltenborn and like all this other stuff. So you're looking at a bunch of philosophies, and the best thing to do is like pick and choose from those, each and every one of them, and you combine them to get your patient better.
right.
Because in
And
the
we've
end,
actually
yeah, go
and
ahead.
we were talking about it earlier that a lot of the techniques are between whatever philosophy you believe in. The techniques that they teach is are very similar. What changes is why you do them. Like, why am I performing this technique? Why am I doing, for example, for manual therapy, right? Why am I doing an oscillation here? Why am I doing a hold? Why am I doing whatever that changes? And it's important. And for me, I think the most important thing as a physical therapist is to understand why you're doing something
Mhm.
rather than just doing it because someone told you to, right? Like, they're like, if you have pain, you do this. It's like, okay, but like, what's it actually doing? Like why am I actually doing this? You know what I mean?
Mm.
Um, so, again, like understanding that approach and understanding that the why from different perspectives, I think that's going to make you a way better clinician.
What's your rationale?
Exactly. Exactly. What's your rationale? And again, like that really what I think that's what distinguishes like good clinicians from great clinicians, from average clinicians, right? Like being able to, treat a patient, understand why you're doing something, and understand not only being able to find what's wrong with that patient, the tissue specific impairment, as we say, like what is actually going on, what hurts, but why does that hurt, right? Like why did it happen? And like and if you treat the why and you find what it is and you treat that, not only is the patient going to get better, but they're going to stay better,
Right.
right? So I think that's the most important part. That's where the clinical reasoning comes in.
Right. And I think it's really important even during my treatments or during an evaluation. I'm always saying, hey, like I'm going to do this because I think this is what's going to help you the best and the reason why for it. So I have some patients who are like, give me all the details. And then I have other patients who are like, just do it and make me feel better.
Right. Yeah. And personally, I love sitting there and explaining to my patients, whether they want to hear it or not. Sometimes I get the blank stares often. Don't get me wrong, but like some people actually want
Yeah.
to know, like why are they in pain, and like what am I doing and why is it helping, right? And like one that gets patient buy-in because they're like, okay, this not only does this guy get me to feel better or improve my function, whatever, but he knows what he's doing, why he's doing things. He's able to teach it and explain it in a way that I can understand, which is also important to them,
Mhm.
because I don't, if I just explain it anatomically, biomechanically, whatever, what's happening, they're going to be like, what are you talking about? Right. But if I can put it in words they can understand, like that's very significant to them. Right. And for me, at the goal, my goal at like an initial evaluation is for not only for me to understand what's going on, but for the patient to know why they hurt.
Right.
Um,
And I don't know if at first, like when you first started getting like a full caseload and whatnot, sometimes you don't know what's going on.
yeah.
Sometimes like it happens. Like I
Yeah,
know I've
it depends how the patient presents, especially if they're in a lot of pain, right? If they're in a lot of
right.
pain, they can't tolerate anything. I'm like, okay, look, like we're just gonna do some stuff to just kind of calm everything down,
Mhm.
and then we'll reassess another day, and that's okay. Like you're not gonna be able, to do a full, evaluation. Sometimes I'll just take a little range of motion measurement, do a little movement analysis, whether it's gait, whatever it is, and then I'm
Mhm.
like, all right, like I got what I need. Let's get you feeling a little bit better, and then we'll kind of assess as we keep going, and that's okay.
Yeah, I 100% agree with that. If you if someone comes in, they're like, "Hey, I've had back pain for 30 years and this is how it is and I know it. I've had PT before, so anything you do is not gonna help." Those patients, I'm not gonna lie, they're probably the most they're they're going to make you a great clinician because at the end of the day, they're gonna challenge you and they're gonna challenge in the sense that mentally they're gonna challenge you and how you treat them and your approach to treatment is what
Right.
I mean.
Yeah,
Because the
chronic pain is
way
very different.
exactly, yeah. Yeah,
Chronic pain is a different beast, and and I've actually again getting good results with that as well. Just by listening to the patient, treating the like more holistic approach, treating the not treating the psychological aspect, but being aware of it and speaking to them in a way that's like doesn't tell me, okay, like you're crazy. It's more like I understand, like you feel this is like a real thing for you. However, this is how it actually is, and
right.
it's important to be able to like get to their level,
Yeah.
um, and not talk at them type thing.
Yeah.
Um,
And it can be sometimes it's just a repetitive movement that they, get stuck in. So
right.
you're always looking at like, hey, how is I mean, I don't know for you, Theo, what do you like functionality wise when you do an exam? So let's say after your range of motion, neurovascular assessment, during like the inspection observation aspect of it, like the first thing I
So
do is looking at them walk in, but after I get all the nitty gritty stuff.
and again, I'm gonna give you the best answer we get in PT school, right? It depends, right? So depends what they're coming in for. Typically, if there's like an aggravating motion, like oh, it hurts when I lift things up, and I'm like, okay, like let me see you lift something up, and I put like a pen on the floor, so I'm gonna pick it up, and they lift it up with the worst mechanics, whatever. Okay, it's like all right, I've seen enough. You know
Yeah.
what I mean? Or, oh, it hurts when I walk. All right, let's see you walk.
Mhm.
Right? And then analyze that motion. So whatever it is they complain for, I'm analyzing it. Now, if they're like, oh, it hurts with everything, and you're gonna get that patient that just like, oh, it hurts with everything. Everything hurts. I'm like, okay, like I'll narrow it down for you. Let me see you walk, do a gait analysis, have them do a squat assessment.
Yep.
If they tolerate that, maybe a single leg squat, kind of see, how strong their hips are. If I
Mhm.
see any knee valgus, overpronation, whatever it is. If it's an upper extremity, I want to see them reach overhead, reach behind back, do a little bit more functional things.
Mhm.
Um, and yeah, I mean, I love, and I also before that, I also try to do like a postural assessment, right? So head to toe assessment, like, and some things might be significant, some things might not be. I think I found good results with grouping things, right? Like if I see a
Mhm.
shoulder elevated, might not mean anything, right? But I also palpate, like, okay, let's see, like, why is the shoulder elevated? Is it upper trap tone? No, upper trap feels fine. So maybe it's their lumbar spine is side bent to one side, and the shoulder now on the contralateral side looks elevated, but
Mhm.
it's coming from the back. You know what I mean? So I'm gonna fix that. You know what I mean?
Right.
Again, I treat what I find. And I take. Uh, I don't just take one piece of the puzzle. I look at the big picture, and then zero in from there.
Yeah. I think that's a good way to approach it because, like you said, it depends. Depends on the patient. Especially like for any lower extremity, I'm always looking at like double leg squats. I
Yeah,
tend to look at like lunges too,
yeah.
or how they walk and
Again,
how they're going.
depends how functional they are. Sit to
Right.
stands, right, for our older population.
Yeah.
And that being said, I would love to take, since we're talking about continuing education, I would love to take like another like an advanced gait course
Yeah.
or something like that. Movement screening, something like with movement screening courses. Like I think I'm always interested in that because at the end of the day, we're movement specialists.
Right.
So,
Yeah.
that's what we find, that's what we treat.
It's funny you bring that up because I recently was at work and I was looking at different screenings. I remember in school we learned the functional movement assessment. So
Mhm.
like where it's double leg squat, single leg, step over like a certain height, and
Right, there was
I
like a
would
rotational one, there was like
yeah,
a bird dog, whatever.
yeah,
Yeah. So all
and
that's
so
good.
yeah, those are all. I mean, those are all good tools to use. I was gonna ask you, what's your favorite outcome measure and why?
I so I use subjective outcome measures sometimes. I'm not a huge fan of them. I just kind of like to see like how the patient gauges the treatment and
Okay.
how they feel like their self-perceived disability, as I call it. Then personally, I like functional stuff. Like I like the 10-meter walk test, for my neurologic. 5 times sit to stand. I like an endurance test, 6 minute, like a 6 minute walk test. We
Yeah.
also do a lot of, so we do like a strength assessment one, a speed, like a gait speed one, an endurance one, and then a fall risk. So we do a 10-meter, a tug, so a timed up and go.
Mhm.
Sometimes I've been enjoying doing with my more advanced patients like an FGA, a functional
Oh,
gait
yeah.
assessment, and because it's like it's so functional, right? Doing
Yeah.
stairs. Are you able to do stairs without holding onto railings?
Yeah.
Um, how are you with turns? How are you with changing speed, right? Like things like that is so functional. So I love that one, and it gives me like such a better picture than some of these other outcome measures
Mhm.
if they're at that level, right? So that's a big if. I never. It's very rare that I actually do that on evaluation day. That's usually like a progress note day for me. I might throw the FGA in there, see how they do, and then score it again at the end and see if they're improved. And for me, I like that one too because it really points my treatment which direction to go. Right. So like, patients not good with stairs. Guess what we're going to work on? Right, stairs. If patients not good with turning, we're going to work on that. So if patients not good with narrow base of support, we're going to work narrow base of support patient, whatever it is. Like I call it, I make a joke, like I do an FGA and then I do an FG treat, right? So,
Yeah.
um, so yeah, I mean, I really love that outcome measure, and every chance I get, and if a patient tolerates it, I use it.
Yeah. I was gonna say the ones that I use the most are probably FGA, modified cat sib, so kind of like standing balance, narrow base of support, eyes open, eyes closed, uneven, even surface. And then 6 minute walk test is a good one that I use 5 times sit to stand. I guess, like you said, depends on the patient, but those are almost like my favorite ones that
Yeah, I
I
have
like
some
to do.
go-to ones, especially when you know the values and you know what's significant, what's not significant. That's also very
Yes.
helpful. So,
Yeah.
because there's so
Tug.
many out there.
Yeah. Yeah, that's definitely those are all definitely good ones that I like to use. And like you said, you use them more and more often, and then you're like, okay, yeah, like I know they should be within this range, 350 meters or however many feet that you convert that into. Or like during the tug tests, you're like, okay,
Yeah.
time to get up and go. Are they using an armchair? Are they getting slow to come up? Did they have to come up twice because they fell down sitting on the chair again because of the first time they couldn't get up all the way. So interesting things like that. For CEUs, so like continuing education stuff. I know we talked about um, manual therapy certification and all that. Does that transfer over as like a continuing education unit?
Of
Okay.
course. The continuing education requirements for PT, at least in the state of Florida, are like super minimal. It's like it's really like you should definitely do more than that, you know. And like for me, like I spend one weekend doing one course, I already met the requirement for 2 years. Like that's the bare minimum in my opinion, and I think we should, strive to be better than that.
Hmm.
There's so much knowledge out there, and like I understand, some of these courses are expensive, and I get that, but we should never stop learning.
Right.
So, keep doing these courses. All these courses count towards continuing education. My company is great that they do every month. No, once a month they do a CU series. So someone comes and presents like a CU, whatever it is. Like this week, it was on on cancer related fatigue. Super
Mhm.
interesting. I see, a good amount of cancer patients or patients that had cancer at some point. And it was great to like, familiar. And I wasn't very familiar with, cancer related fatigue, and not still not an expert or anything, but I definitely feel like more familiar with able to have those conversations. Um, so that's also, fantastic.
Yeah, that's good. That's good because like every like in services basically.
Right.
And
Right.
those are always good to have, especially when you work in a setting where you get a lot of outpatient general, so you're getting anything, which is
Everything,
just
everything. I think
neuro.
yeah, I think the next one we're gonna get is like a pediatric one. Again, I see very rarely, but I see some kids. I think the youngest I've seen is 7, you know.
Wow.
So it's good to know, you know.
Yeah, absolutely. Yeah, that's a big one because I've I've haven't treated anyone, I think, under 10. I think 10 or 11 was
Mhm.
the cutoff that I had. And it was just a couple treatments, and they were a swimmer or a dancer or something like that in Florida. But after that, it's just like they kind of bounce back pretty quick, especially since they're young and agile and they're
Yeah,
quick to heal.
definitely.
um, Along the topic of having different like CEUs and manual therapy course, do you see yourself having like any leadership or being a leader in the PT community?
I think you're more of an expert on that topic than me, to be honest. For me, that's something I've thought about. I don't know if that's super like priority for me right now.
Hmm.
Maybe not like a couple years. I consider taking some, like a leadership role or leadership continuing education. For me right now, since I'm just starting out, it's more just improving my skills, and just
Yeah,
treating patient, like getting people better faster.
right.
That's very into that right now.
Yeah, no, I am with like a leadership group right now through work, but I think the biggest thing, like you said, is I just want to get my patients better because I'm seeing it and I know I can get them better. And I feel like if I'm not getting any continuing education, course or taking any continuing education courses, that I'm not doing my job as a PT.
Right.
But at the end
Because
of the day, like you're doing the best that you can, and
yeah.
yeah.
Right.
All right, everyone. Theo, do you have any last words before we get?
Yes. So if anybody has like questions, especially about orthopedic stuff, reach out, hit us up. If you have questions about fellowships, how to start, where to go, first job, whatever it is, manual therapy certifications, different approaches to treating, whether it's like University of St. Augustine or Grimsby, whatever it is, Mackenzie method, reach out. We can have conversations about that. Now, if it's anything other than that, neuro stuff, maybe I can help, maybe I can't. Again, reach out, and if I can't help, I'll find out.
Yeah, absolutely. You guys are more than welcome to reach out on Instagram. We also have a Facebook, I believe, through the podcast. Any way, email, whatever you guys want, YouTube, you name it. Just reach out to us, ask us some questions. One of us will answer. If I don't know it, I'll ask Theo. If Theo doesn't know, he'll ask me. We'll go back and forth. We'll find out the answer. We'll do it together.
Yeah,
Biggest thing here is there aren't any dumb questions. Trust me, as a
yeah.
new grad, you ask the right amount of questions.
Slide in those DMs, okay?
Sounds good, right? All right, guys. Thank you for listening to our podcast, Physio Minds. Go ahead and leave a like, a subscribe, something for us. That way we know you guys are listening. We really appreciate you guys listening. This is our 10th episode. I can't believe we did 10 episodes already, which is pretty crazy
Impressed.
to me. It's impressive.
Considering
Okay.
how busy we've been, how much we've been slacking on this, but yeah, it's great.
That is very true. But thank you guys so much. We truly appreciate it.